Hello, everybody, and thank you so much for joining us today. It's my pleasure to introduce our guest speakers, Kevin Kennedy, Luke Gard, and Dr. Elizabeth Friedman. Mr. Kennedy is the director of the Environmental Health Program at Children's Mercy Hospital in Kansas City. The program provides patient families, child cares, and schools with resources to assist them in identifying and reducing indoor environmental exposures that may result in health problems. Mr. Kennedy has been involved in environmental health science and industrial hygiene chemistry consulting for over 30 years and has been a champion for safe and healthy housing and works to help programs integrate environmental health, energy efficiency, and resiliency in the built environment through teaching, research, and advocacy. Mr. Gard has nearly 30 years of experience in the field of environmental health. He began his career in environmental laboratories, performing various analysis and helping develop analytical methods. In 2005, Luke began working in the environmental health program at Children's Mercy Hospital, and within a year, he developed a healthy schools program and began working with districts to identify concerns through proactive audits of facilities with recommendations for improvements. He also has developed numerous trainings for various school audiences to increase environmental awareness and provide staff with best practices for creating and maintaining optimal conditions for occupant health and performance. And Dr. Friedman is an environmental physician with extensive training in pediatrics, internal medicine, preventative medicine, and occupational health and environmental medicine, as well as public health. She works as the Region 7 Mid-America, and I'm going to say this in acronym, I'm going to spell it out, or it's PEHSU director. You'll learn a little bit more about that later. And she's also the medical director of the Environmental Health Program at Children's Mercy Hospital in Kansas City. In today's Health Bites, our speakers will give a presentation on the role of indoor environmental hazards on the health of children. Thank you so much for being our guest speakers this morning. And right now, I'm just going to turn this all over to you.
All right. Just pulling up my slides here.
Great.
All right, can you all see my slides?
Yes.
All right, so thanks so much, Margie, for that introduction. Like Margie said, I'm going to be talking, well, we're all going to be talking about this really fantastic environmental health program that I had the privilege of joining a couple of years ago. First, some housekeeping. I want to acknowledge that we're on the traditional territories of the Kickapoo, Arkansas, Osage, and Oshedi-Shakowin. Over the years, our team has done work with some of the regional tribes, and we stay committed to serving everyone in and around our region, including tribal members. Also, we have no conflict of interest to report. So in our introduction, Margie mentioned the PEHSU. PEHSU stands for Pediatric Environmental Health Specialty Unit. And like she said, I'm the director of the Region 7 Mid-America PEHSU. So we're a network of federally funded clinicians with expertise in prevention, diagnosis, management, and treatment of health issues that arise from environmental exposures from preconception through adolescence. Take note that in addition to education and outreach, we provide consultation services to clinicians, health departments, and community members. So, please don't hesitate to reach out to us with your environmental health questions because we are here to serve. So now let's get started. The Children's Mercy Healthy Homes and Healthy Schools and Childcare programs are both about 20 years old. They were developed by teams and primarily led by my co-presenters today. So I'm going to leave it to them to discuss the programs. I'm simply starting off the presentation today with some background contextual information on how the environment and health interact, and specifically how the environment affects child health. So first, how does environment impact our health in general? So in March 2016, the World Health Organization published the second edition of this report called Preventing Disease Through Healthy Environments. And in it, their main findings are these. Nearly 1 in 4 deaths in the world are due to environmental factors, whether that's air, soil, or water pollution, chemical exposures, adverse effects of climate change, injury on the job. They also report that environmental impacts are experienced unevenly through different groups, often related to social groups like income, status, employment, level of education, but they also are different across gender, age, and ethnicity groups. And lastly, they report that environmental disease burden is preventable. And in this report, they cite proven strategies for preventing disease and death through healthy environments. So, this makes sense theoretically. How does it play into our lives here, and how does it play into our kids' lives? Well, we have building codes and we have rules to keep us safe. But are the practices and laws that we have in place enough, and are they enough to protect our children? This is a huge conversation that's been going on for a long time, and hopefully this presentation, along with some of the other presentations in Health Bites, gives you some additional insight. So let's talk about childhood diseases. In the past 150 years or so, pediatric diseases have changed a lot. Previously, infectious diseases caused most pediatric illness. And today, in the US and many other industrialized societies, the principal causes of sickness and disability and death are now chronic diseases. Rates of the diseases listed here have all increased substantially over the past decades. According to the CDC, autism spectrum disorder prevalence has tripled in the past 20 years. Asthma prevalence has more than doubled in the past 2 decades and has become the leading cause of pediatric hospitalization and school absenteeism, sans COVID, of course. And obesity has trebled in prevalence, and its consequence, type 2 diabetes, has become a problem of epidemic proportion among US children. And cancers, leukemia and brain cancer in children have increased in incidence by more than 30% in the past 50 years, despite declining mortality. Likewise, testicular cancer in adolescents and young men have increased in incidence by more than 50%. And there are a lot of people out there who believe these changes, at least some of them, can be attributed to environmental factors. Recent studies have found that living near dense traffic is associated with asthma, exacerbation, and development. Research has shown that exposure to BPA, a chemical used in plastics, is also associated with the development of asthma. And there is a huge body of literature that points to these correlations. Okay, children are not little adults. They are uniquely vulnerable to environmental factors. There are behavioral and physiologic differences between children's bodies and adults' bodies. And the developmental components of a child's physiology is changing. It's maturing, it's growing and differentiating. These growing periods are called developmental windows. And there are also critical windows of vulnerability. For example, during organ development, that create unique risks for children exposed to hazards that can even alter normal function for the rest of their lives or alter organ structure. Then, children's environments are changing over time based on their abilities. So when they're small and crawling or sitting on the ground, their breathing zone is closer to the ground. And then they also have this age-appropriate hand-to-mouth behavior. So what they touch often ends up in their mouths and being ingested. Children also may have a more limited ability to understand consequences and move out of harm's way. And this can persist through development from the exploratory period of toddlerhood through adolescence during high-risk behaviors that we see there. Also, due to their developmental physiology, children often experience higher exposure. So you could even say higher doses to pollutants found in air, water, and food. And these exposures can be handled differently, in part because their organ systems are immature compared to those of an adult. So one example would be that a child's liver isn't fully developed for a number of years. So they're going to metabolize certain chemicals differently than would an adult. This can explain, for example, why a newborn wouldn't have the same type of toxic response to a really high dose of Tylenol than an older child might have. Another example taken from this list and how children are uniquely different is that they have a longer life expectancy. They have a longer shelf period. So if they're exposed to a carcinogen, for example, they're going to have a longer time to manifest a disease with a longer latency period than would someone who's quite elderly. And the list goes on, but I'll keep it here to keep us on track. So we've talked a bit about how children are uniquely vulnerable to the effects of small amounts of chemical exposures in our environment. We're going to talk about the chemicals for a minute. In the late 1970s, the Toxic Substances Control Act, or TSCA, was passed. And this requires the EPA to compile, keep current, and publish a list of chemical substances that are manufactured or processed in the US. And when TSCA was enacted in the late 1970s, there were over 60,000 chemicals already in commerce. And TSCA didn't require that these companies producing these chemicals provide health or environmental safety data on these chemicals. They were grandfathered in. And since that time, there has only been a testing of about 200 of these grandfathered chemicals, and only 5 chemical groups have been banned. And that's because TSCA places the burden of proof on the EPA to show that a chemical is dangerous, rather than on chemical companies to show that they are safe. And that is very, very different from how we approach medications. And we consume small doses of medications similar to these chemicals. So just some sort of a comparison there to kind of give you some context. Also under TSCA, something we talk about are high production volume chemicals. These are chemicals that are produced in quantities of more than 1 million pounds per year. And some more statistics, only about half of these chemicals have undergone basic testing for potential toxicity, and less than 10% have been tested for developmental toxicity or toxicity to children. So let's talk about this indoor chemical context. According to a recent review, there are about 30,000 chemicals in indoor dust or indoor air and on our surfaces, and only about 280 of these have been identified. And this is in part because some of the chemicals are actually produced from a reaction between household products and building materials. So these aren't chemicals that we've introduced, but that are being created by what we've put in our environment. The NHANES study, or the National Health and Nutrition Examination Survey study, which started in the 1960s and then was redirected in the 90s, through this study, we conduct surveys, blood and urine analysis of thousands of people around the country each year to assess for different metabolites or breakdown products of different exposures, allowing us to know what we're being exposed to, and in some ways to what extent, and also how we may be breaking down these chemicals. And this is part of what's called biomonitoring. And through NHANES, we have seen that blood lead levels throughout the US population are continuing to trend downward. Similarly, cotinine, which is a metabolite or a breakdown product from nicotine, those levels continue to trend downward. But what we're also seeing is that certain chemicals in our environment are becoming ubiquitous, that a majority of the US population carry in their blood phthalates, BPA, and these are chemicals that are used in plastics. BPDE, which is in flame retardants, PFAS, per and polyfluoroalkylated substances, which are in a variety of products, including nonstick cookware and flame retardants and stain-resistant products. In another study from 2016, a meta-analysis, which is sort of a study of a whole bunch of studies on a similar subject, these researchers estimated what an adult dose in quotes, would be of indoor household chemicals. And what they found in studying these chemicals is that in our household dust, we're also being exposed to some hazardous chemicals, including carcinogens, which cause cancer, endocrine disruptors, which affect our hormone systems, chemicals that can interfere with our immune systems. And you can see the rest of this list here. I want to take a quick moment to remind folks again of that first slide from the World Health Organization and remind you all that people with fewer economic means, and frequently people of color, are those who bear a greater burden to our use of these chemicals in our environment, meaning these exposures to potentially harmful chemicals are not happening uniformly across all populations. You can see that from this slide that children of color, particularly Black children in the state of Missouri, are experiencing higher rates of lead exposure than other children. Likewise, in the state of Washington, most communities of color are experiencing higher rates of pollution than white people. This is something we see again and again. It's real and it's a problem, and we can do better. And while addressing these injustices and these exposures at a population level through policy, deliberate and strategic planning and development would be more effective, we are able to affect some change at an individual level by working with our patients, and at a community level by working with our schools. In our Healthy Home and Healthy Schools programs, we aim to reduce risk by reducing or removing hazards or exposures. And so if we use asthma for an example, there's sufficient evidence that asthma development and exacerbation are associated with these environmental exposures or triggers. And one of the ways we serve our patients is by identifying these hazards in the home and finding ways to reduce or remove them. A lot of research has been done to show sufficient evidence exists that we can improve health by taking on the interventions listed here. And research is growing and other interventions are being implemented and studying for efficacy. So I'm going to pass the mic to Kevin Kennedy now to talk to you about how we've been able to assess and improve home environments for children in Kansas City through Healthy Home.
Confirming you can see my screen?
Yeah.
Wonderful. Well, thank you, Dr. Friedman, and thank you everyone for being here and for listening today. So as you heard, I'm Kevin Kennedy. I'm the director of our program. I am, like Luke, we are both environmental hygienists for the program at Children's Mercy. And Dr. Friedman provided a nice overview of how our exposure to things in the environment is connected to our health, especially the health of children. And many, many years ago at Children's Mercy, we, in recognizing the role environment plays in disease, and especially in chronic respiratory disease and allergic disease, developed these programs that we're going to mention today. So in looking at the role of environment, the intent here is that families can be referred to us regarding their child with a particular chronic health condition where the environment they spend time in may be impacting their health, and the family is struggling to manage that child's disease and manage their overall health. So let's look at this from the perspective of a child. So here's Jimmy Lawrence. And Jimmy was referred to our environmental health program because of a long history of lung disease and a compromised immune system. So the good thing is our program serves the service area of the hospital, which is about a 200-mile radius of Kansas City. So we can take referrals within that larger area. Many of them come through our own system. Any provider within the Children's Mercy Network can make a referral to our program so that we can talk with the family about what potential concerns and risks they may be reporting and see if we can help. So our program, as you heard, has been around for over 20 years now. We generally have 3 programs under the Healthy Home Program umbrella. We have an asthma-friendly home program that's focused on working with asthma patients and allergy patients. We have a childhood lead poison prevention program. And then we work with complex medical kids who might have more than one health condition or might be immunocompromised or have some unique condition that makes them particularly vulnerable to the environment. Over our 20 years, we have done well over 2,000 home visits, and we've had the good fortune of having grants to support home repairs where we actually can make repairs in the home. And we've used the program and the patient-focused services to also support research, and then we do education and training that I'll mention later. An important thing to understand is we provide this service at no cost to Jimmy's family. We support this through some of the community benefit from our hospital as a nonprofit, through the grants that we've received, some donations, some foundation support, and then there are occasions where a family can enroll in a research study, and the research studies we focused on the Healthy Home Program have been related to home interventions and seeing the benefit from those. And interestingly, we just recently received a $100,000 donation from the local gas utility, Spire, a generous support for our Healthy Home Program. So just pointing out through this study, this is a systematic review of home environmental intervention programs, looking at what worked. And so this is a nice algorithm that shows the steps in the process. So the environmental assessment along with in-home education and then the environmental remediation, the interventions in the home, the combination of those are known through a whole bunch of different research, including our own, to improve health, improve quality of life, and reduce the cost and burden of, in this case, asthma. But really, we've seen that with other health conditions where it's reduced the burden of those healthcare costs because you're eliminating or minimizing the amount of exposure. Another way to look at this in the healthy home world, many of you may be familiar with an epidemiologic triangle. This is a great way to visually represent disease and how someone's exposed. And what you see here in the lower left is the environment of our triangle. On the lower, the lower right. On the lower left is the agent, the thing that might be causing the health condition, and at the top, our host or occupant. So looking at those, then the connection is through either some kind of transport mechanism, which is either a vector, an animate or living thing, or a fomite, an inanimate thing. So the triangle does a good way of showing how these things are connected within the home environment and how, in this case, a child is exposed to those conditions that might lead to either the development of disease or making their disease worse. Another way to look at it, our philosophy in doing our work is to try to reduce exposure. So we're trying to reduce exposure for Jimmy. We can't just look at the contaminant sources in Jimmy's home. We have to think about the reservoirs in the home and what we call the facilitative factors. And all of these are connected together. Our approach in exposure reduction has to be to address all of these at the same time. So once Jimmy's family is referred to us, then we have several options that we can offer. Either it's some kind of education, or maybe we can send them resources, or maybe we can refer them to other programs in the community, or we can offer them a level of assessment and then maybe some work on their home to try to reduce exposure. In collecting information, we have a systematic process for collecting information. We want to collect some health information, but we also want to collect what's called an environmental history, a history of where Jimmy spends time, a history of the house, a history of time in the home, and then specific conditions in the home that might represent indicators of exposure risk. So looking a little more closely at the questions here, you can see we're asking, when was the last time anyone observed any water leak, stains, or mold anywhere in the house, with the answer options being last week, last month, last 3 months, or last 6 months. So we're trying to get an understanding of how recently there may have been exposures in the house. So this 10-question survey is a great starting point for us to understand what might be going on in the home. So we combine that environmental history along with looking at their past healthcare utilization, and then we use what's called an asthma control test to understand the current control of Jimmy's asthma. So the combination is used to develop what we call the total asthma risk. And we use that so that we can stratify our clients into different levels of risk and then offer a level of service based on the level of risk, environmental risk and health risk that they're reporting related to the environment. So a low level risk, we offer a basic education service. A high or severe risk, we do an intensive investigation in the home and collect careful information and maybe even measurements and samples to try to understand what the exposure is and then what repairs we're going to make to eliminate that exposure. So in Jimmy's case, then, the next step is what we call a case review. That's where our team would get together, review some of the concerns that have been reported to us, and then talk about what would be the best service that we might be able to offer to Jimmy's family and whether we need to connect them to other resources to try to have these things happen simultaneously if possible. So our goal with all families is several interactions, because if you're going to do work on homes, it takes time to get in and get out and make sure that those interventions, the repairs, have done their job. Also, as you're working with people, you're trying to change behavior and get them to understand why they should be doing certain things more often in their home, for example. Touches or interactions over time allow us to support the education that we're advocating for. The next step is to visit the home. So when we go to a home, we are evaluating all aspects of the home. So we're looking at the outside, we're looking at the conditions around the outside of the home, we're looking for things that outside that might influence the indoors, we're looking at all the mechanical and systems and appliances, the general conditions of things, anything that indicates a potential environmental risk or a potential exposure risk. We are one of the many programs that apply the 8 healthy home principles as strategies for working with families and getting them to systematically focus on the issues in their home, so that we're organizing our information that we provide to them under these 8 categories. And those are: keep it clean, dry, pest-free, contaminant-free, safe, ventilated, comfortable, and maintained. And that way we organize the information in simple ways and simple messages that they can understand. When we assess the house, we're looking again at the whole house, the building, the mechanical systems, the appliances, but we're also visiting each room, and we've developed a systematic assessment protocol. That's what you see on this sheet on the right. It's a scored and rated system looking at the different keep it principles that I just mentioned, and we're looking for evidence of and the presence of exposure risks like excessive dust, gas fumes, airborne chemicals, physical conditions, chronic dampness. And all of these things, as Dr. Friedman said, they can react with each other. They can relate to each other and enhance or exacerbate exposure in some way. We look at the appliances, especially combustion appliances. We're concerned about risks associated with the chemicals they produce, making sure they're functioning properly. We're looking for evidence of things like candles and incense that do produce pollutants that people are being exposed to. We're asking families about their home management practice, because home management, both the frequency of their activity and the products they use can make exposure risk worse or can be the source of the exposure risk. Some maintenance, of course, can make exposure better, because if we can teach them to clean more often and techniques in their cleaning to reduce potential exposure, then that's beneficial to the family. So as we visit spaces, as we assess exposure risk, we're thinking about the whole system. So here we're looking at a child's bedroom. This is Jimmy's sister. Looking at the bedroom, we want to know, where are the supply vents that supply air to this room? What kind of circulation is there? Is there evidence of moisture issues? Then we're also looking at specific risks. We can see lots of things in the room. It's probably hard to clean the room. There's settled dust, and that can create additional exposures if they can't get in and effectively clean. And the same applies to really any space. We can look at this room, which is very different from the previous bedroom, but yet those exposure risks still exist here. You still have those reservoirs within this room that represent different types of exposure. So really any space we can offer education about effective ways to manage that space and reduce the potential for exposure. We assemble our information into what we call an assessment advisory plan. It includes the scored and rated conditions that we saw based on our assessment. We try always to identify things that are good. We try to offer positive reinforcement, and then we make recommendations. Our recommendations are specific for the family, for educating them, but also interventions, home repairs, fixes we're going to pay for using our grant dollars to try to improve environmental conditions. Many times we also collect measurements and samples, so we want to present that information in a way that families can understand it, so we color code that information as well. That's what you're seeing here, is that anything color coded green, we can tell a family that informs them that these things are good. This aspect of your home is good. Those things color coded yellow, there's caution. Those things color coded red are a take action, something we're going to help them address. So we assemble an assessment information, we offer education, we offer healthy home cleaning and safety supplies, and then looking at the home, identifying what we think are the exposure risks. We do specific interventions in the home, specific fixes or changes to try to improve the environmental conditions in the home. All of that is our systematic process that sometimes takes several months in working with some of our families. And we've had the good fortune of having several grants over the 20 years to fix hundreds of homes. So this is just a summary of some of the common things that we've done in homes. Remember, all at no cost. So we very commonly are doing furnace cleaning and maintenance, repair, plumbing repairs, carpet removal where needed, sometimes intensive cleaning of the carpet if it's in fairly good shape, all sorts of exhaust ventilation systems that we've put in to try to improve air circulation within a house, try to improve moisture management, and then many safety devices are included in that. Our average cost over the years has been right around $2,300 for the interventions, and then an additional healthy home safety and cleaning kit that often includes a vacuum and some other things. So all of those, again, are paid for through donations and grants at our hospital. So we recently did an analysis right as COVID was hitting of the 94 families that had participated just prior to that, and we found significant declines. And we've seen this historically. This was just another one of our reviews, but significant declines. You can see a 60% decrease in ED visits, 81% decrease in inpatient stays and PICUs. Now, we can't say specifically it is our program that has done this, but it's certainly one of the services, the comprehensive services that we offer asthma patients that helps reduce that utilization. And you can see that breakdown here in cost savings, ultimately leading to a net $5,000 savings, including the cost of our assessments and the interventions in the actual homes. We also teach classes. We've offered training classes now for about 13 years. Both Luke and I are trainers. He focuses on schools. I teach all of these classes, and they're available on our website, and we can provide more information to you. So that's a summary of our Healthy Home program, how we might help families like Jimmy's family. And I'll turn it over to Luke, and he will tell you about our schools program.
Thank you, Kevin. Thank you, Dr. Friedman, and thank you, Margie. Let me go ahead and see if I can get my screen shared here. And I'm having the same issues I had before. All right, can you see the presentation?
Yeah, you want to switch displays.
Okay, thank you. All right, everything looking good now?
Yep.
All right, perfect. Well, good morning, everybody. I'm going to get the opportunity to speak about something that's near and dear to my heart, and that's what goes on in schools. I am our Healthy Schools Program Manager, and with the support of Kevin Kennedy, back in about 2005 or 2006, right after I started at the hospital, we were doing reactive investigations in schools for situations that may have occurred, and he allowed me to kind of turn the program into more of a proactive program where we were trying to work with districts to help them identify issues before they really became problems. So before we really start the discussion, we have to understand that schools face unique challenges. They're the most densely occupied buildings, and really what I want to focus on is this last bullet. Oftentimes, because we're focusing on educational needs, computers, books, things like that, budget dollars for maintenance and renovation are oftentimes forced to a lower priority, which means that we may not have optimal conditions in our buildings. There has been some research done that connects student success in the classroom and how it's influenced by various variables that you can see here. This was a document that the EPA put out in November 2012, and it basically shows the connection between performance and these different variables. The reason why I highlighted indoor pollutants and contaminants in red is if you look at all the variables above it, they're really single variables. When we talk about indoor pollutants and contaminants, this may be everything from carpeting and upholstery, dust. This may be allergens brought in on backpacks, clothing, personal care products that the staff may wear, all sorts of things. And so this is a really complex area as you try to understand what may be going on. About 30 years ago, the EPA created a wonderful document called the Indoor Air Quality Tools for Schools Kit. It's been around that long. They don't support it quite the way that they used to just because of financial issues, but it is a great proactive tool. The problem with the kit is, if you've ever seen it, it weighs about 4 pounds and it gets plumped down on a nurse's desk and they are told to start an indoor air quality program. And as a result, you can see here, about 10 years after the introduction of the IAQ Tools for Schools kit, only 42% of districts actually reporting having an IAQ plan in place. And you can see on here, and I just want to point these two different terms out, you can see the term IAQ in the first paragraph and IEQ in the second. We prefer the term IEQ because it means indoor environmental quality rather than just air. So it's a little more comprehensive or holistic as we look at the contaminants in the space. In 2007, which was about 10 years after the original Tools for Schools kit was developed, the EPA updated that with what they called the 6 key drivers for success, which are the organize, communicate, assess, plan, act, and evaluate. And then they also created what they called their Super 6 technical solutions. And you can see those in that middle bubble there. We developed our forms independently of the Tools for Schools kit because we already had a Healthy Home program, and I kind of expanded that thought process into schools. But our forms very closely resemble the EPA's Tools for Schools stuff. Another great resource that's available free to the public for schools to use is the CDC School Health Index tool. The version that you see here is the elementary school version from 2017. They do have a middle and high school version as well. But basically, this is a document that allows districts to evaluate existing policies, activities, things like that. So fundraising activities, safe routes to school, education and training for staff. It's extremely comprehensive. And again, it's free, but it allows districts to understand where they may have some deficiencies or weaknesses that they should focus on. I would be remiss if we didn't talk about asthma in schools. And you heard Dr. Friedman early on mention that asthma is the #1 cause of school absenteeism. And there's a debate in the statistics, but sometime between the 80s and the early 2000s, literally asthma doubled. It is the #1 chronic disease among children and adolescents. And as you can see here in the second bullet, it is the #1 cause of school absenteeism. So if we can manage asthma in an effective manner, we're going to have kids sitting in their classroom and more able to learn. Asthma episodes are typically associated with exposures to a variety of contaminants. And Dr. Friedman did a great job of talking about many of those. Here's just another kind of summary to reiterate that. We've got the dust mites, pets and pests when we talk about rodents and things like that, cockroaches. Those fragrance products can be respiratory irritants, smoking, diesel exhaust fumes. And I also want to point out just this last, the slide in the lower right there of the corner, we actually introduce contaminants into our buildings when we're doing what we should do, which is cleaning and maintaining them. Hopefully we have enough time to allow those chemicals to dissipate before we reoccupy the building. And I really, really think this is something we learned from one of our first districts that we worked with. And I always like to include this in presentations because it shows some of the challenges when we talk about asthma management. I'll briefly run through this. This was a small school district. Schools 1 through 4 are all elementary schools. And you can see school 4 also has an early childhood. So now we also have some more susceptible children. School 5 was the middle school, school 6 was the high school, and school 7 was the alternative school. So the first thing you'll notice, especially as you look at schools 1 through 3, is we have frequent flyers. We're seeing kids that are visiting the clinic for asthma over 50 times in a school year. This means their asthma is not in control. The other thing I want to point out, these are de-identified student ID numbers. So if you can look at the first 2 numbers up in the upper left there, 2608 and 436, if you move from school 1 to school 3, those students also attended school 3. So this also illustrates sometimes the transiency nature of some of the students, the socioeconomic challenges that families may face, and as a result, asthma management and care may go to a lower priority. Now let's discuss why school 4 is so unique in terms of the elementary schools versus the other 3 schools. And what had happened in school 4, they were all about the same age, but they had actually redone a majority of the schools. So they had redone the windows and doors, a new ventilation system, and basically that new exterior and the new lungs for the building, as you can see, led to significant improvements in occupant health and reductions in clinic visits. Now, the last thing I'm going to finish on this slide, and this is where it becomes a little bit concerning when we talk about asthma management. Schools 5, 6, and 7, as I indicated, were middles and high schools. The reason why we don't see as many clinic visits in those environments is because typically around 5th or 6th grade, the school nurse comes to a point where they feel that that student can self-medicate. They can use their inhaler when they need it, and they don't need to come to the clinic for supervision. The problem with this is we don't know in what areas of the building the children may be having to use rescue inhalers, and we don't know how many times during the day that may be happening. So that's an indication of somebody's asthma not being in control, and without the nurse knowing about that, that child's asthma management and care may suffer. So one of the things that's gotten a lot of play just in the last 20 years is mold in general. And I want to use this slide to kind of connect the dampness and mold piece together and really emphasize that we really should be focused on management of moisture and dampness. And as a result, we shouldn't have any of the resulting mold. So from this study, the conclusion indicated the presence of dampness and mold has consistent positive associations with multiple allergic and respiratory effects. So we know the presence of dampness and mold causes symptoms. Thus, the prevention and remediation of indoor dampness are likely to reduce health risks. So we're not talking about testing. We're not talking about doing anything else other than remediating those areas that I have identified dampness and moisture in, and doing a better job of managing moisture in our building. That in and of itself, those best practices should reduce the associated health risks that may exist. The first thing that we come into this with this philosophy is being proactive. And we recommend to districts to have established policies, to follow the policies, to have good documentation. And what this does is this basically highlights the administration's effort to maintain a standard of care. And this standard of care term was reinforced in the 2004 U.S. Department of Ed report on schools, which basically stated, and I want to bring this home in terms of best practice and building operation. At present, the evaluation of good IEQ is not based on indoor exposure limits. We do not have indoor exposure limits in homes and schools, but it is based on good practices of design, maintenance, and operation of those buildings. So we're not worried about the exposure limits. We're really worried about how we operate those buildings. Good practices of design, maintenance, and operation. When we work with our school groups, we really try to get everybody involved. We have a district level team and then the building level team. The building level team should definitely include that principal, that lead custodian, that nurse in the school, and ideally a teacher representative so that they can communicate kind of these meeting issues back with the rest of the teacher population. And again, we're not asking people to reinvent the wheel. If you can integrate this into a health and wellness or a building administration meeting, it's just one more thing that would be on your agenda in those meetings. We also work with districts to evaluate their existing policies. So you can see over here on the left-hand column in this particular district, we've gone through and basically written out their policies. And then the EPA Tools for Schools has a healthy seat policy recommendation. And then you can see CMH recommendations may even go a little bit farther. But we're basically trying to give them the tools to create good policies and procedures to maintain that standard of care. We also, and I think Kevin did a great job of pointing this out, we provide staff and education and training for a variety of audience in both homes, schools, community professions, etc. But we've got asthma education for nurses, education, a one-day training for the maintenance and custodial staff that has 8 modules on how to maintain a safer and healthier building. And then we've got some other education opportunities for staff that occupy the building, and we offer them best practices. Now, you heard that epidemiologic triangle that Kevin mentioned earlier. This is a different kind of take on that, but it includes those same variables. So we've got the 4 Ps of these healthy buildings, and this is really what we're trying to teach the building staff, the people that are managing the buildings. We've got the people in the building, and oftentimes we're more concerned about the sensitized people, the canary in the coal mines, because they're going to be the first ones that respond to things. We're worried about the pollutants. What kind of pollutants are there? We're worried about the pathways. Sometimes this is as simple as opening and closing a door. It may be unintentional through a wall chase or a cavity. And then we're going to use pressure. Natural pressure is wind forces driven from outside, or the stack effect where warm air rises inside. Mechanical is where we're actually turning on the HVAC system and delivering air into the room, fresh, filtered, conditioned air. And then we're going to remove that older air to, again, restart that process. As Kevin indicated, we do like the color coding. We have that systematic process for evaluating seven domains. We include photos in all of our presentations because it does a great job of illustrating the issues that you identified. And now we haven't forgotten little Jimmy. I want to take a walk through Jimmy's school, and we're going to talk about some of the good and the bad things we see here. So as we go in through the door here, we can see it's a welcoming environment. We've got nice hallways, tile hallways. We've got some mats you can see on the upper right here coming out of the restrooms. Some of the issues that we're seeing is by putting some of these upholstered chairs and things in the hallways, it makes it harder for the custodial staff to clean and maintain that space. And then when we put those chairs near an entrance or exit, as is the case in the lower right-hand photo here, we're creating a significant hazard in an emergency. So now let's walk into Jimmy's classroom, and it's a welcoming classroom. This district, if you go back, already did a great job of removing wall-to-wall carpeting, so we've got tile floors. Unfortunately, the teacher is going to introduce a number of area rugs, which we'll see here. This is that HVAC system that we talked about. This is that unit ventilator. So that black line that you see across and above the rabbit's cage right there is the supply vent for the room. So that is blowing air into the classroom. If it is blowing air over a rabbit and a cage with bedding, probably urine soaked, you can imagine what that classroom would smell like. Well, now let's look at the bottom part of that same unit. This is the return vent. This is where that stale contaminated air that basically has been in the room for a while gets removed and basically drawn back into the unit. It gets reconditioned and filtered. And as you can see here, with this being obstructed, we don't have that ability to do so. And this room had a stale, just kind of sticky, muggy feeling to it because we weren't really removing that stale contaminated air from the room. You can imagine the odor that was coming again from the air being blown across the rabbit cage. So what are we going to do? The teacher's then going to put in a plug-in air freshener. So now we have a chemical fragrance product that may be a respiratory irritant. Now let's take a look over by the sink. And if you look over that bean bag, you can see just right over that door in that bean bag, you can see kind of a pink and a green jar. Those are candles. So in addition to the plug-in air freshener, we're also using candles in the classroom to try to cover up those disagreeable odors. I want to look more closely under the cabinet, but before we do that, I want you to see that there are no cabinet locks on this elementary classroom, these doors here. So children have access to these chemicals that I'm going to show you next. So in this particular case, this was what was underneath that sink. We've got multiple abrasive cleaners. We've got 2 cans of graffiti remover, which is a strong solvent. You can see nail polish remover here in the lower right. That's acetone. That's another strong solvent. A variety of cleaners and air fresheners here. And then the thing that concerns me the most about it as an assessor is this green bottle with the red lid and some dark liquid in it that's not labeled. So again, we couldn't even tell you what hazard may be associated with that. And then finally, in Jimmy's classroom, unfortunately, we have some moisture issues. So this is where we want to, again, use best practices, address the problem, resolve it, and then that should reduce any of those health symptoms associated not only with dampness, but mold as well. And I want to use this slide. It kind of makes me sad that we have to use this slide, but we really recommend this proactive approach because until we have standards to really evaluate the environment and compare the environment to, we're always going to use our sensitive populations, such as young children and immunocompromised people, the elderly. They are going to be our canaries in the coal mine. And as a result, unfortunately, they have to go through the symptomology and express discomfort and pain. And it gets to that point for us to finally understand we need to do something about the environment. we're heading down the home stretch here. I want to leave 10 minutes for questions if possible. What's at stake and what are the benefits? Improved health, that seems pretty apparent. 37 states have a funding formula where every day that that child sits in the seat at school results in additional funding for that state. So the first district that we talked to, that we worked with, a 1% increase in their average daily attendance. So if we went from 92 to 93%, that equated to about $500,000 in revenue from the state. So healthy buildings can help the districts actually increase their revenue stream from those funding sources. And then if you're sitting in the classroom, you're breathing and you're healthy, it would certainly lead to improved academic performance. I want to leave you with an exciting opportunity that's kind of come up in Missouri over the last couple of years. With the onset of the pandemic, a lot of organizations reached out to the PASU and Dr. Friedman for assistance and guidance. And what it's allowed us to do is work with three of the key kind of stakeholders in the state of Missouri, the plant managers, the school nurses, and the school board association, to develop a holistic approach with forms, trainings, walkthroughs, all these other things that should serve the state of Missouri. And the reason that this is exciting for us is we're not aware of anywhere else in the country that is really doing this. And then the last slide here. I'm going to let you read these things. We've talked about being proactive. We talked about being holistic. I really just want to leave you with that last bullet, and I've already read it once, but at present, the evaluation of good IEQ is based not on those indoor exposure limits, but on good practices of design, maintenance, and operation. And with that, I will leave it. I'm going to turn it over for Dr. Friedman for one last slide, and then we'll have room for questions. Let me stop sharing here. There we go.
Okay, well, I've lost my transcript, so I'm going to wing it. This is really just a last summary to bring it all together. And for those of you who are following along with the PDF, we have hyperlinks included on this slide. Just a quick summary, we have a pretty robust program here. With our Healthy Homes program and training programs, we provide assessments and then recommendations and often means for implementing that intervention at the home level. For our schools, we provide assessments, feedback, and training as well. And then with PASU support and the environmental medicine expertise, we've been able to update our education and outreach materials, as well as support additional trainings, including our community health worker training for the Healthy Homes program, which we are working really hard to make more accessible, not only regionally, but also nationally, and in multiple languages. So, you know, we're very proud of this program, and I want to encourage you to check out our website, and please don't hesitate to reach out to us for, you know, questions, concerns, or anything related to environmental health. Margie, it's been a real treat to present and share some of our work with your audience. So thank you so much for having us.
Thank you very much.
Thank you.
Thank you. I mean, this is incredibly fascinating. Just enjoyed listening to all of the good work that you're doing. So I would like to open the floor for questions now. So if you have any questions for our group or our presenters, just please pop us in the chat. Okay, great. So we have one. So for the home program, how do you support individuals living in apartments or other rented space who are not authorized to make repairs to their home?
That's a great question, and a significant portion of the families we work with do live in rental property. Our goal, of course, would be to work with the landlord and see if they would be amenable to some of the repairs we're encouraging. Because we have the grant funds to pay for those repairs, many of the landlords are interested and willing. And in some cases, when we visited the home, we identify code violations, so we may negotiate with the landlord to say, we will address these issues if you will address these code violations, and try to use our funds as an incentive for additional repairs and try to target our funds to the things that aren't necessarily a code violation. Code violations are things they should certainly be required to take care of. If we can't do that, then we may work with other community partners to try to help the family find another place to live that might be better for the family. So it's a mixed bag as far as how we can work in rented spaces.
I'd like to add to that. So we recently partnered with the Environmental Legal Clinic and the Medical Legal Clinic, well, the Environmental Legal Clinic at Washington University in St. Louis and the Medical Legal Partnership at Children's Mercy to address some of the housing justice issues that are implied in this question. And it's our hope that we're able to find means to serve our patients more effectively living in these situations, and also develop some partnerships regionally with landlords so that we can more effectively address the needs of our patients without uprooting their lives.
One unique thing to to Kansas City, Missouri, is there's a healthy home rental inspection program as well. So we can refer them for that rental inspection. That's unique in the country.
Great. So I have another question of how do you protect yourselves when doing walkthroughs of homes? So for instance, homes where drugs were manufactured or used may be dangerous, but not immediately obvious.
Well, that's certainly going to be a risk. We don't necessarily know the whole history of the house and activities that might have gone on there. We try to gather as much information as we can as part of that history of the home itself. And certainly there can be, active drug use that we are not aware of. But that's part of teaching and stressing the importance of your own personal safety and awareness of any home you go into. So that's just part of it. We carry personal protective equipment in the cars that we use because we do see other things besides just something that's significant. It's kind of rare for us to have referrals for families that are manufacturing drugs while allowing someone to visit their home. They're more likely to not allow someone to visit their home. So we're typically going to people's homes who are receptive to us being there. But the point you also pointed out there is they may not be aware, especially if it's a new house they bought or a new rental that they've moved into, that it was used before as a drug house. I know the state of Missouri at one time was maintaining a list of what those drug houses were, and the state had a formal process for going through and decontaminating their homes, those homes, but there's no guarantee.
And then just a quick add-on to that, if I could, just the bottom line is this brings up a great question. We are oftentimes not protected when we go into these homes, because if we walked into just any random environment or every environment with a Tyvek suit and a respirator on and all these other things, we'd scare the heck out of our clients. So yeah, we do assume some risk, and we use our gut feelings and common sense and all those things to protect ourselves when we need to.
So we have time for just one more question, and here it is. How receptive to these environmental changes are the schools, and how often do you see change?
They are very, very receptive. In most cases, they're more receptive to the information. And a lot of this stuff, for example, when we go through and do an assessment, and if we see a number of rooms that had chemicals stored in unlocked cabinets, that's a low cost or a no cost fix. That's just more of a procedural or kind of setting up a process for evaluating and make sure we don't have those things. On larger things, a great example would be we just did something a couple of years ago where they had exposed vents. Condensation was forming on those exposed vents, and that was an investigation. When I went back to do the routine facility audit of that facility, they had redone that whole thing. So in most cases, districts want to eliminate the problems if they can, and certainly with schools, finances are always going to be a challenge. But that's a great question.
Well, thank you so much for this really informative and wonderful presentation. It's just been really interesting, and I certainly have learned a lot. So again, thank you for being with us today, and we hope that we can have you come back and update our audience about more of the work that you're doing.
Thanks for watching. This video was produced by the network of the National Library of Medicine. Select the circular channel icon to subscribe to our channel, or select a video thumbnail to watch another video from the channel.